high. Waiting times for all treatments and support is on the up. Staff are feeling the weight as they try to get through an endless backlog. And as we've already heard, the money that might be needed to fix the problems may not be coming anytime soon.
So what can patients expect if they find themselves heading to an accident and emergency department this winter, and how are those departments facing up to the challenges in front of them?
Well, Dr. Ian Higginson is Vice President of the Royal College of Emergency Medicine, representing our A&E staff, and joins us on Sunday morning. Welcome.
Good morning.
Good morning. Let's start with nurses, because, of course, one of the big stories of last week was that a strike had been decided. We haven't had a date for that action yet. How concerning is that for you, for your work? And do you think, NHS staff obviously work very closely together in A&E departments. What kind of an impact will it add to an already difficult situation?
So thank you. It's worth pointing out that I won't be able to comment specifically on strike action, just because our college is unable to do so. But we would anticipate that emergency departments remain open and functioning during any industrial action that would occur, although we would be concerned that anything that changes the way the health service operates around us may place additional pressure on our services.
And I suppose give people a picture of what it's like working in A&E right now, because everyone will have their own stories of, trying to phone for an ambulance or knowing somebody who's tried to do that and really struggled. What are the pressures? What's taking the time? I mean, why is it so difficult at the moment?
Okay, so there are very few emergency departments that are in good nick. There's a few that are in difficult times, and most are in a pretty desperate state right now. The main problem is that we cannot get our patients from the emergency department into hospital beds, and that's because hospitals are full. When that happens, we then have patients stacking up in our emergency departments, and those poor patients often end up either in our corridors, where we can't look after them properly, or they may end up waiting in ambulances to actually get into the department. What that means is that ambulances are then queuing outside our emergency departments, so they can't go out to see those patients in the community who've called for them. So what you get is essentially a really big traffic jam. But that traffic jam affects human beings, our patients, and it means that we have to look after them under terrible conditions sometimes. We have to look after them in corridors, in places that might have been cupboards before, in rooms that are cleared out of stuff and magically renamed treatment areas, in structures in front of our departments. The lights are on all the time. We struggle to keep them safe if they are at risk of falling. We struggle to feed them. It's very hard for us to help them to go to the toilet. They can't wash adequately. So for our poor patients, it's really difficult. And then our staff are living with that, and they find it really distressing and really difficult. So our staff are suffering from the effects of trying to do the best they can under such difficult circumstances.
So what would solve the problem? Because some people say, well, there needs to be more money for the NHS. Others say the NHS has a huge budget already. It needs to become more efficient. And then there's a big question about social care, which sounds like that's what you're sort of heading towards, the idea that hospitals are blocked. We need to remove patients and put them somewhere else. What's the big fix?
So the big fix is proper strategic planning and really proper leadership of our health service. What we would hope that would lead to then would be adequate investment in both health and social care. But with investment in social care, it may be possible for patients to be looked after in the community, which would free up hospital beds. The other things that we would like to see are an increase in the amount of working across the working week in hospitals and later in the evening. So many hospitals are still structured as if the world only worked between 9 and 5, not 7 days a week. And the services that we need in order to support patients in hospitals don't exist across the week. And that also causes problems for us and is a contributing factor. The final thing would be primary care is the bedrock of the NHS, and that really needs to be working effectively along with public health so that things can be dealt with properly in the community without even having to come to hospital.
I'm really interested that you say that hospitals are not working as efficiently as they could be at the moment in terms of working hours. Should there be a 7-day rota, do you think? And why is that not happening when we know that there is a huge backlog in the NHS already?
So many staff in the NHS already work across the working week. 7-day working doesn't mean that we all work 7 days. It means that we spread our efforts across the working week. Now, what that means is you need to have enough staff to man those rotas. For instance, if you've only got 10 physiotherapists and you need all those 10 during the week, if you spread them more thinly, if you spread the butter more thinly over the working week, it means you don't have enough physiotherapists either at the weekend or during the week. So part of it's due to the numbers of staff that we have available, and part of it is due to the culture that has developed in the NHS over the last 50 years. So a move towards providing the same service for patients on urgent and emergency care pathways across the week would certainly make a contribution. But make no mistake, the biggest issue by far, we think, is access to beds, and that's about numbers of beds and social care.
What do you mean by the culture of the NHS that's grown up over the last couple of years?
Oh, no, not over the last couple of years, over years and years and years and years. The NHS, if you go back 20 years, very much operated on a model of a standard working week. Now, the urgent and emergency care system has moved away from that gradually, so that in ambulance services and emergency departments and many acute specialities now work across the working week and late into the evenings, because that's when the patients come in. But that's not the same for all services. Now, that culture has driven the sort of workforce decisions that underpin our inability to deliver that care across the working week. And the combination of the two is the long-standing problem.
Do you think there is criticism that can be levelled at the NHS? Because often when we have this conversation, politicians find it very difficult to do that. They talk about efficiencies, they talk about trying to find ways to work better, but they stop short of saying some things the NHS is doing are not working and need to change. I mean, do you think that, what would you pick out as your criticism at the moment of the way that things are working that could be done better?
Well, I think anyone in the NHS would say that we could do things differently and better. But also anyone who works in the NHS would look around them and say, it's really, really hard for us to make those improvements when we're working in the situation that we're in. So when you haven't got enough beds, you haven't got enough staff, you haven't got enough time, those staff are exhausted, they're overworked, and they're really just trying to keep their head above water. It's very hard for us to make the sort of improvements that are needed. There's no headroom. The lack of headroom is absolutely the responsibility of health service leadership and political decisions and health policy decisions over the last 10 years. And that is not the fault of the NHS. So I wouldn't criticise the NHS. Those of us working in the NHS would say we could do things so much better. We know how to do things so much better. We need to be given the tools to do things better. So I think I would invert the question. I say I wouldn't criticise the NHS, but I would recognise that we could do things a lot better were we given the opportunity to do our jobs properly.
You mentioned people are in some cases being treated in cupboards in spaces that are not intended to be treatment areas, and that there are knock-on effects of that. Is it having an impact on care now?
Undoubtedly, it's having an impact on care. So we know that crowding in emergency departments is associated with increased numbers of patients coming to harm. And by that, we mean that their care isn't as good as they might be, so they get more complications, or they might have a higher risk of dying as a result of the illness that they have. So there's loads and loads of evidence to say that is happening. Now, it's a combination of things that leads to that. Some of that is because if emergency departments are struggling, then hospitals are struggling, so the care in hospitals won't be where we would like it to be. Some of it's because staff can't work effectively and efficiently under those sorts of conditions. And it may be that some of it is because patients change the way that they seek help because they worry about coming to our departments because they know the reality, which we don't want to hide from patients. We'll still do the best we can, but some patients also delay coming to our departments or cannot access our departments because of problems getting to ambulances. So there's all sorts of reasons for that, but we know that care is suffering. And as a result of that, staff are suffering because they're all a bunch of highly trained professionals. They know what they can do, but they can't deliver the care they would like to under the current circumstances.
I'm interested that you say that people are changing the way they come to hospital or thinking twice about it. If someone you knew, if your friends or family needed emergency help, would you tell them to rely on an ambulance, or would you tell them to try and make their own way to hospital if they needed it?
It's a difficult question for me to answer because I have a specialised knowledge of the way that the system operates. So the advice for our patients has to remain to contact the relevant, what are called gateways, so things like NHS 111 or 999, and take the advice that's offered to them by those skilled professionals who are working in those services. Now, sometimes operators on ambulance services on 111 will recommend the patients make their own way to hospital rather than coming by ambulance. Sometimes they will recommend alternative services that might be a benefit to them. So I think that's what the public should do. Those of us who work within the system can make those decisions based on a different set of knowledge about the risks involved. So contact NHS 111, contact 999, contact primary care, and take the advice that's offered to you.
And just finally, how would you characterise how A&E systems are working at the moment? If 1 is not very well at all and 10 is brilliant, where are we on that scale?
It varies between departments. So some departments, specialised departments, departments with a different set of circumstances are working much better than others. But on the whole, we are really, really worried about the way things are. Staff are suffering from considerable anxiety often about the care that they're able to deliver. And we're worried that we're not seeing the sort of long-term plans that are going to get us out of this over the next few years. So rather than put a number on it, I would say that we're really worried about the way things are. And what we want to see is some realistic strategic planning to help the health service, the urgent and emergency care system, pull its way out of this. And emergency departments are obviously a very important part of that.
Dr. Ian Higginson, thank you for joining us this morning. Well, a look at the Sunday papers after past, and next we'll hear from the man